and is now the leading the transplant and cellular therapies for hemoglobinopathies at King's. She has been also heavily involved in the UK Hemoglobinopathy Forum, as well as doing work nationally at BSH, and she's also currently the chair for the clinical reference group for hemoglobinopathy. So I welcome her, and we look forward to hearing this talk.
Thank you, Siobhan, for this very, very kind introduction. I'm really honored to be here. Thank you, Panisha, and thank you, Professor Basu, I don't know if he's here, for inviting me to this talk. We've been here before in another UK Forum meeting, so it's a venue that I'm familiar with. So I'm going to mainly focus. So as Siobhan has already explained to you, there isn't a huge amount of drugs available in hemoglobinopathies. In fact, we haven't had. In fact, we are on a negative balance when it comes to drugs, because there are drugs that are being withdrawn and permissions being withdrawn rather than new drugs being added. So we're in a deficit right now. But I mean, it's I don't want to do doom and gloom. There are additional things that it'll be interesting to see what the future holds, but right now we have a few things to play around with, and I was asked to talk about some of the therapeutic options that we have for curative treatment. So I'm aware that this is a new topic, and Siobhan and I are probably in the minority, absolute minority, in people who are interested in forging a career in a non-cancer hematology. So I'm going to do some case-based discussions. This is just an overall kind of information sharing opportunity for me. So rather than doing sort of 3 abstracts that came out in ASH last year, and also I did tell Panisha that I didn't go to ASH last year, but he said, don't worry, you can say whatever you like. Okay, so these are my disclosures. So I'm going to start with this picture that it was published a long, long time ago now. No new drugs came in since then, but it was more than 13 years ago. New drugs came in, but were removed. So this is just a funny way of representing the prevalence of sickle cell in the world, and this is proportional to the number of newborn babies in the world and are likely to be in the future. And so you can see that it's disproportionately in West Africa, in Central Africa, and quite surprisingly also in India, which is a country that people tend to forget that it is very prevalent. So that it is projected that by 2050, 3 countries in the world are going to be the largest supplier, let's say, of newborn children with sickle cell disease, and that is Nigeria in West Africa, Democratic Republic of Congo, which is sort of in the middle, and India. So India always comes as a surprise. We don't see sickle patients from India in this country very often, and that is because most of the sickle patients who are in India come from very deprived, very isolated, tribal and forest-dwelling communities of the middle part of the country. And there is very little social mobility in that group of patients, so they tend to stay very local. But it is a massive issue in India. We're not talking about India today, but I'm just FYI. And the other thing that has come out very recently, is there a pointer here, do we know? No, it's fine, don't worry. The other thing that has come out very recently is what a killer sickle cell disease is. So sickle cell disease now accounts for, or when properly assessed, sickle cell disease actually is the 12th largest cause in the world for children under 5 dying. If you look at cause-specific mortality, sickle cell disease is number 40. This is a very sort of morbid, scale of performance scale of deaths. But if you children with sickle cell die of other things as well, and taken together, all the things that they die of brings those children at the 12th highest cause of death in the under 12. So this is a real important problem, real global problem. And right from when slave trade happened, when indentured labor replaced the slave trade, and more latterly through migration, sickle cell is a worldwide problem, including the global north, not just the global south. And, you know, we've talked about this unfortunately, this ends in 2020, this picture, which I took from Professor Thien, who happens to have won many awards this year, and I'm going to go through that later. Absolutely brilliant scientist and hematologist who used to work in King's a few years ago. And so this is just to say that sickle cell was recognized as a Western kind of disease, as it were, more than 100 years ago. And in the 100 years, we've had only a handful of discoveries that have been, like, you know, really groundbreaking, so much so that you can include them all in one slide. Since 2020, we've had 6 more years, and the main thing that has happened is some introduction and withdrawal of drugs that look at managing sickle cell complications, and more importantly and life-changingly, the approval for the first time in the world of a gene editing therapy in the NHS. Since then, it has been approved in many other, and I only say NHS more importantly is because it's a sort of publicly funded healthcare system. It was approved prior to that in the US, but in terms of publicly funded healthcare systems, NHS, England was the first, followed by Scotland, Wales, and then we've had other countries, and Saudi and a number of other countries approved since then. So, I mean, these are just the ones that are mostly problematic in terms of clinical complications. Sickle SD Punjab is something rarer, but very, very problematic, very symptomatic children and adults, and often end up needing curative treatment. And this is just a kind of downstream. So although sickle cell disease itself is a very kind of what seemingly looks like a straightforward mechanical blockage of the abnormal sickle-shaped red blood cells into the peripheral capillary circulation, there is a lot more to it, as we have known for the last 50 years, and which leads to downstream effects such as microvascular occlusion, hyperinflammation, splenic dysfunction, you name it. But obviously there's just a single gene defect. So supportive therapy, sadly, is not very many. Systemic supportive therapy with, just hydroxycarbamide, and there have been large studies that has really shown the effect of antibiotic prophylaxis and vaccination and so on. So curative therapy in sickle cell. So allogeneic stem cell transplant, actually, like everything else in sickle cell, quite a lot is extrapolated or learned from our cancer treating colleagues. And again, the first sickle cell disease, the first transplant was done in a child with sickle cell anemia who also happened to have had acute myeloid leukemia, and the transplant was done to treat that, and then it was discovered that both her conditions were cured as a result of that. And since then, that was in the 80s, and since then we've had a huge amount of learning gained from various studies all over the world. For all of you cancer doctors here, these kind of survival rates will make you very envious. So we have a 97% overall survival we have a massive disease-free survival rates. But equally, there is quite worryingly for us, there is high graft rejection and high graft versus host disease rates. And that is, of course, been the challenge. You do not want to change one chronic disease, sickle cell disease, with another chronic disease, chronic graft versus host disease. So you really need to give, need to plan preconditioning treatment in a way that you avoid any kind of graft versus host disease as much as you can. So they generally tend to be deeply lymphodepleted, conditioning treatment or depleting conditioning treatments. We don't need MRD. There's absolutely no need for MRD. We don't need GVHD. Not MRD, I mean GVL, beg your pardon. We don't need GVL because there is no L to GV. So we just want better engraftment and less rejection and less GVHD. Okay, so the best outcomes are with matched sibling donors, but the other thing is that matched sibling donor availability is shockingly poor. It's not just because there is a Mendelian kind of 25% chance of having your a sibling donor match in your family, but also the fact that some of those 25% of the children will also have inherited the sickle gene in homozygosity, and therefore the actual availability is way less than that. It's less than 10%. And unrelated donor availability has improved, but we're going to talk about unrelated donor transplants later. So matched unrelated donor, these are the standard kind of complications, which I don't really need to go into details. So the main thing that we understand in allogeneic stem cell transplant for sickle cell disease is that there is a significant impact of age, although I will refute my own claim in a few slides later. If you are an adult, there is an overall lower overall and event-free survival. And there is higher graft failure and graft versus host disease, without a doubt. And that's to do with the fact that we are unable to use the similar kind of conditioning treatment as you would use in a young patient. And of course, we have in our last 3 or 4 years experience, a little bit more than that, 5 years experience of since transplants were made available for adults in sickle cell disease. It wasn't available until 2019, and because it coincided with the pandemic, we were only able to start in 2022. And so just in the last 4 years, we, in the UK experience, has been interesting in the terms of actual real-world experience in getting people into the transplant, into the program, getting them come in and receive their chemotherapy and so on. It's been, disease severity has been, a significant. Is it worth taking the risk of coming to cure versus, okay, well, I'm managing, I'm not doing that bad, that kind of conversations. So I'm going to talk through case studies. I think probably that's the easiest way of keeping people a little bit more focused, because we're all clinicians here. So this is a 6-year-old child with sickle cell anemia, was diagnosed prenatally. First crisis was at age 4 years. This was at a time when universally hydroxycarbamide was not being afforded to our children. At age 5, she developed an abnormal transcranial Doppler, which essentially means that you're at a high risk of developing a stroke. Children with sickle cell anemia have about 300 to 400 times higher risk of stroke than a child with hemoglobin AA. She also had obstructive sleep apnea, which was treated with tonsillectomy. She was started on hydroxyurea at a later age of 4 years, which resulted in normalization of her TCD velocities. Her MRI was normal. At 6 years of age, she presented with parvovirus B19 infection, caused severe anemia, aplastic crisis and seizures. She had bilateral white matter infarcts and watershed area of the MCAs, which is a very, very common thing we see in sickle, so it wasn't something that we hadn't seen before. But essentially what had happened was that she developed, within a period of about a year, very severe cerebrovascular disease, so bilateral strictures or obstructions in her middle cerebral arteries, including the development of moya, which is this quite dangerous and prone to bleeding type collaterals. So her sibling was a full match. So these were the therapeutic options at the time: continued regular transfusion, continued transfusions through to 18, and then changed to hydroxycarbamide or workup for BMT. So she did undergo a BMT with standard myeloablative conditioning because she was the right age for that. She had an excellent response, and she had evidence of full donor hematopoiesis all the way through. So what is the point of doing allogeneic transplants? So this is an old study. This only goes up to 2010 by Mike Walters, who has been a pioneer in transplants in sickle cell disease. And he followed them up and essentially showing that even after 14 years of long-term follow-up, you get a fantastic survival, overall and event-free survival in patients who've undergone sickle cell disease with very good quality of life. No painful episodes, no episodes of acute chest syndrome, no splenico-hepatic sequestration, no red cell transfusion requirement, no stroke, TIAs, or hemorrhagic CNS events. So it almost feels like it's worth putting your child or your patient through this procedure. So this is more recent data, effectively just reflecting what was published in 2010, showing if you think of the straight line at the middle on the left side being the day of the transplant, and events on the left meaning pre-transplant, event on the right meaning post-transplant, you can see what a phenomenal improvement that transplants do. So in real life, this cure, that so-called cure that you're achieving, or a real cure in this context, actually makes a big difference to the clinical outcome of the patients. So yeah, so I mean, I know we perhaps don't need to justify, but you know, if anyone wants to justify, these are, I would like you to point to, see this slide. And then, okay, if you've got really bad cerebrovascular disease, that too helps in transplant, so your chances of having a new stroke, chances of having worsening cerebrovascular disease improves significantly. So this was old data from 2010, more recent data from 2024, really beautifully demonstrates that post-transplant, so blue is good, red is bad, because you've got this very high, the idea is that there is high cerebral vascular flow causing damage, and the control of the vascular diameter within the cerebral vasculature is very poor with sickle cell, and you can see how beautifully it is settled afterwards. So this is another case diagnosed at birth, multiple vaso-occlusive crisis, commenced on transfusion because didn't respond to hydroxyurea, kept getting some pain even whilst doing that, so improved compliance on hydroxyurea at the time, hydroxycarbamide, hydroxyurea, the same thing, sorry, I might interchange. Comments on automated red cell exchange or bone marrow transplant. So the only medicine we have, hydroxycarbamide, does sometimes not work. What is the option in this situation? So this one also had a BMT conditioning, and this BMT from a sibling. This was a few years ago, so she then had quite a slightly old-fashioned type of Bucy transplant with alemtuzumab pre-transplant and GVHD prophylaxis with cyclosporine and methotrexate. She had this transplant many years ago, and occasionally I bump into her. She's doing phenomenally well. So, you know, there are good success stories. So what are the barriers? Firstly, I've already said that children will not have, many children will not have donors. So what about alternatives? So unrelated cord blood, unrelated bone marrow, mismatched related bone marrow, or haploidentical stem cell, peripheral stem cells or bone marrow. So these are the essential options. So this is just a picture to show you that searching for a donor in sickle cell BMT is very, very challenging. 54% did not have. And in the end, only 1% got transplanted in this particular study. So this is a 20-year-old female, long history of recurrent pain, you know, very, very, very complex sickle cell disease. Sibling is HLA matched. So this is an adult transplant. This is what we have now been allowed by the NHS to use. This is a very, very low intensity, no chemotherapy, only a low-dose TBI and Campath conditioning. And this is the reason why this has been chosen, is because these patients come to us really broken, really multi-morbid at a very young age, and they will fall apart if we give them anything stronger. So whilst you're giving them very deeply immunosuppressive, deeply lymphodepleting conditioning, they are not particularly myeloablative. The whole concept is mixed chimerism, because it's been shown that if you have even as little as 20% myeloid donor chimerism, you will be free from crisis, or in the context of thalassemia, free from transfusion requirement. So this is the essence of this. Very, very high. This was the original paper, 2009. This is what I mean. It's taken us more than 10 years in the UK to be able to use this treatment, published in 2009 by the NIH group in the New England Journal of Medicine. But this particular study showed also a very high risk of graft rejection. And then when those individuals, adult patients, were followed up a few years later, 29 out of 30 patients survived, and there was no graft versus host disease, and the death was an unrelated death. And so even more recent data using the same kind of platform. This was from colleagues from the UAE, and they've shown a fantastic overall survival. So what happens if the graft fails? So because it's not a particularly myeloablative conditioning, the patient resumes and sort of assumes sickle hematopoiesis. So it's his or her own donor hematopoiesis returns. So we don't have this kind of death as a result of or relapse. We will effectively have relapsed hematopoiesis. But even so, for people who do transplant for malignant conditions, this is a remarkable outcome. So 6-year-old boy, this is has multiple problems, particularly to do with their cerebrovascular disease. Despite being on transfusions, their cerebrovascular disease continued to progress. Unfortunately, his sibling was not a match. So either you continue with red cell transfusion, but you can add in hydroxycarbamide. You refer for neurosurgical procedure, maybe there's big stenosis, you can get the surgeons to bypass it somehow, improve your cerebrovascular circulation, or proceed with unrelated donor BMT. Now, I'm only telling you this because this child did proceed with unrelated donor BMT. It was a very, very challenging procedure mainly because of the risk of bleeding, risk of seizures, risk of cerebrovascular complications as a result of the conditioning protocol. So did have an unrelated donor transplant, and it was hugely complicated by engraftment syndrome, grade 3 GVHD of gut, needing, you name it, and they had every complications under the sun as a result of this. These outcomes have improved with post-transplant cyclophosphamide, and I'm going to talk about that in a minute. He had a full and sustained molecular evidence of hematopoiesis from 1 month post-transplant to follow up at 4 years post-transplant. So he did well, but it took a very, very long time for him to, come out of his graft versus host disease and other cerebrovascular complications. So this was a trial of an unrelated donor transplant for sickle cell patients. This study was needed to publish this study because people were doing unrelated donor transplants in isolation in various parts of the world, but actually this kind of essentially put it to bed. Unrelated donor transplant is not an option in sickle cell disease. Patients do extremely badly. If you think about, what we showed earlier, this compared to that, this is really bad. We had particularly very, very high risk. Chronic GVHD, 60-70% chance of chronic GVHD. As I said to you earlier, we do not need chronic GVHD in a chronic disease. So this was not an acceptable option. And deaths, there were 7 young people who died, and they were all early sort of older teenagers. So again, this was, a tragic outcome and essentially the nail in the coffin of unrelated transplants in this context. So 8-year-old boy, multiple vesicular occlusive, again, a stroke, progression of vasculopathy, only child, no unrelated donor transplant, no unrelated donor. So this one is the haploidentical protocol. I do not need to tell you about haploidentical studies because they've all come from the malignant world, as I've mentioned before. And so this is the backbone that we use in haploidentical donor transplants. The same thing, low-dose TBI, fludarabine ATG, followed by and cyclophosphamide, followed by post-transplant cyclophosphamide for in vivo T cell depletion. Some people have also done ex vivo TCR alpha beta depletion procedures. The ex vivo is not that, due to cost and everything, it's not really that popular in the world right now. There were large numbers of rejection, if you see the last column, and that has been circumvented by giving pre-transplant immunosuppression, usually by high-dose hydroxycarbamide and occasionally azathioprine. And this is more recent data from, in this context, again, fantastic outcomes both in adults and children. So I think haploidentical stem cell transplant opens the floodgates. Virtually every child will have a haploidentical donor, hopefully, and many, many, many adults have haploidentical donors as well. Maybe not their parents necessarily, but siblings usually. or cousins or whatever, half siblings can have them. So this is a really, really promising outcome. Right now, it's not routinely commissioned in the UK. There is a study that some of you may be aware of called the Redress study, which is a head-to-head comparator study looking at haploidentical transplant safety, efficacy, and cost efficiency of haploidentical transplant versus standard of care in the UK. We're hoping to have results by 2027 and hoping to have this commissioned as standard in the UK. Brings me towards the end of this talk. Now, gene therapy, this is what's the latest, as I said to you. Gene therapy, because it's a single gene disorder, gene therapy in hemoglobinopathies have been around as long as gene therapy concepts have been around. So, but people have really struggled for various reasons, which I don't really want to go into. But what has happened now and is now accepted as a sort of, as routinely commissioned in the UK is this gene editing therapy. There is also a gene insertion therapy, which is available in the US by a lentiviral vector by a company called Bluebird Bio, which is now called something else. And that company decided to withdraw its commercialization in Europe a few years ago, but I hear that they are going to return. There are other companies, biomed companies, that are trying other lentiviral vector products, including some non-commercial academic institutions are also trying to include. But as far as clinical practice is concerned, real-world people are concerned, gene editing therapy is currently the only available. And this is an ex vivo treatment, so you apheresis stem cells from the patient, send it to the company, which is called Vertex. Vertex and CRISPR Therapeutics, which is Jennifer Doudna's company. So they have come together to provide this, and basically it uses the CRISPR-Cas9 technology to suppress a gene called BCL11A. And BCL11A is upstream of the gamma globin, so which makes fetal hemoglobin. So fetal hemoglobin is very, very protective. It's an anti-sickling hemoglobin. It's very protective against sickle cell. And so this was known for as long as we've known about sickle cell disease. There are natural paradigms such as compound heterozygosity of S and HPFH, or hereditary persistence of fetal hemoglobin. These patients are completely clinically normal. So this is a way of mimicking the natural paradigm of sickle HPFH by basically disrupting the expression of a gene called BCL11A. And that was the most stunning discovery of the last decade in gene expression. And it started with Professor Swile Thien in 2007 in King's College London, where she discovered that BCL11A hugely influences the expression or the suppression of expression of hemoglobin F. It then took off in the US. Unfortunately, there wasn't enough funding available to make that happen to understand the biology of that in the UK. But the US, basically people from Harvard, they, very, very 20 years of research, cutting it a long story short, discovered that there was an erythroid-specific enhancer, which you can actually, if you actually remove that erythroid-specific enhancer, so essentially makes BCL11A unable to suppress the expression of hemoglobin F. So you're kind of switching off a gene that switches off hemoglobin F. So it's a difficult concept to get your head around. It's a difficult concept to explain to families, but this is essentially what's happening. The main the barrier is because it's ex vivo. Two big barriers that people are experiencing right now in real world. One is the challenge to apheresis stem cells in our sickle patients. We cannot use GCSF because it can be very, very problematic in patients with sickle cell disease. There are examples of death in GCSF-treated sickle cell patients. So we can only use plerixafor, and the quality of stem cells or the quantity of stem cells are very poor, and often people need as many as 5 rounds of apheresis. For all of you who do peripheral blood apheresis, you will know that having 5 rounds of apheresis will be so challenging. The second challenge we have is that it requires a myeloablative conditioning for the autologous transplant, and that myeloablative conditioning can only be busulfan. That's the only thing that has worked. Therefore, automatically, anybody above the age of 40 is not eligible for this kind of transplant, because we all know what happens if you give myeloablative conditioning to older people, particularly with busulfan. So I think I've kind of said that already. So apheresis on the top, conditioning, transduced stem cells on day 0. Everything, all the excitement, is, all of you who look after autografts will know, excitement happens before, and it is very anticlimactic afterwards. They do phenomenally well if it works, particularly in the thalassemia setting. We've all now begun, thalassemia was the disease that was first approved, so we all now have patients who have gone through the apheresis. It takes about 6 months for the drug product to be made, and we've now myeloablated our patients, returned the drug product, and they are doing incredibly well. So the challenges, of course, is, as I said, ex vivo procedures, collection of stem cells, and more importantly, giving these myeloablative conditioning. This is the exa-cel product, which is now available. Again, very similar to the picture I showed you earlier. If you think of the red bit in the middle, the long line, as the time where they had their transplant, swim plot, right-hand side, post-autologous transplant, left-hand side, or post-gene therapy, left-hand side, pre-gene therapy, and each little blue dot is a sickle vaso-occlusive event. You can see how phenomenally they have responded. And this study has now ended, and they have effectively met the primary endpoint of 98% people after their transplant had 1 whole year without vaso-occlusive crisis. So 12-month vaso-occlusive crisis free was the primary endpoint of this study, and that was concluded very successfully. So who qualifies for gene therapy in the UK? Patients followed by a comprehensive center for hemoglobinopathies, the genotypes as such. No HLA-matched family donors. We have to make sure that is the case. It's only available for patients over 12 years. The 5 to 12-year studies are still ongoing, and it's you have to have 2 painful crises per year for 2 years, with no response to hydroxycarbamide at maximum tolerated dose, either alone or in combination with other treatments, or at least 2 acute chest syndrome in the 2 years. So you have to be really, really severely affected. The one problem we are facing is that we give for people who have multiple vaso-occlusive crisis and have failed hydroxyurea, we normally give them transfusions. So if they're a long-term transfusion, they don't get pain. If they don't get pain, they don't qualify. So it is quite a terrible situation to be in. If you're doing well on transfusions, you want a transfusion-free life, you cannot qualify for gene therapy. So that's another challenge we have. So what happens next? So the one that I told you is gene editing. We've talked about gene therapy, gene insertion therapy with lentiviral vectors, gene editing with CRISPR-Cas9. Gene editing causes double-stranded DNA break. This base editing will cause single-stranded DNA break with homology-directed repair and non-homologous end joining repair. There is base-edited DNA, which could be actually less genotoxic than the CRISPR technology. And not to be undone, there is new technologies coming through. This is prime editing. And these are all sort of either in primate studies right now, have gone through the mouse studies and rats and so on, and is now in primate studies. This prime editing hasn't come to in-human studies yet. And then the other exciting thing is in vivo gene editing. So essentially, you inject the patient with some kind of a gene editing product, usually with lipid nanoparticles, which will then constantly provide, a bit like mRNA vaccines, putting it very, very superficially. You vaccinate them or you treat them. It might require multiple injections, maybe 1 injection a year, 1 injection every 6 months, who knows. But this is going to happen right now only in mice, but hopefully this will be the future. So in summary, huge new field of endless potential to get scientific advances from bench to bedside. Hemoglobin disorders are most prevalent in countries where none of these techniques are likely to be implemented due to extremely high cost. CRISPR-Cas9, the exa-cel product, is 1.67 million per drug, and that doesn't even include the autologous transplant or the cost of the apheresis or anything else. So the main focus really is to reduce cost, improve scalability, but also get the basic care of hemoglobin disorders right. So these are my acknowledgements. This is my end of my talk. The middle picture was taken here a couple of years ago, and you can see Shivan resplendent in red in the middle. So thank you to everybody who helped out in this very orphan and slightly Cinderella area of hematology. Thank you.
That's an excellent talk. I was talking to Vikram Matthews in CMC Vellore. So they are working on, I mean, one thing you mentioned about haploidentical transplants, they are doing TCR alpha beta regularly, and they are working very well.
Yeah.
So that's one,
It's not, we just don't have the infrastructure to use it in the NHS, and I've just made it quite NHS focused, but you're right. Germany does it a lot as well, and obviously many countries are doing it, including Velo. Yeah.
So in 2024, ASH, there was this study from France, Dr. Bernardin. They have a large series, they presented excellent data. I mean, 204 patients, they have done allogeneic stem cell transplant, excellent outcomes. So what has prevented the uptake of allogeneic transplants in the UK? And they had more than 50% matched sibling donor, which is very impressive. You don't get more than 15% according to your slide.
Yeah.
So what is that? Is there a difference between the population?
So François Bernardin normally she's a pediatric transplanter. So all the data you heard from her is pediatric data. It's not adults. So I was focusing a little bit across all ages in my talk today. So in terms of numbers, we have been doing in the UK sibling transplant for sickle cell disease for over 25 years. So that's very standard of care, that is very well known. I showed you some data from the US, I've shown you some data from just the outcomes and so on earlier in my talk. So the question was, are we doing them? Yes, we are, but they're probably, again, reflecting the kind of lack of, I don't really know why, but we haven't had the culture of including these procedures within study frameworks so that they can then be published. But I can assure you that we have also had in the UK many hundreds of patients that have been transplanted, children, sibling donor transplant. But they are unfortunately have not really been published as sort of systematically as perhaps ideally we should have done. So that is a deficiency for us. So, unlike the MRC ALL studies, we know right from, it has been one of the highest success rates in terms of, getting patients included in at least even in observation studies. Unfortunately, that infrastructure does not exist in sickle cell transplant.
The cost implications of patients once they develop, for example, Shivan knows we had a patient with anti-U, and
it's very difficult. You're absolutely right, and and that is one of the outcome from the redress study, which we are hoping will come out by 2027, is just to be able to demonstrate that standard of care in sickle cell patients is very, very expensive. Yeah.
And should we be considering the transplant before they develop the complications?
Yes, and that's also a very, very good point. In fact, there is a policy proposal. In fact, I didn't get into that, but there was a recent publication actually suggesting the very thing. and they've published, basically what they've shown is that if you transplant asymptomatic children early on versus symptomatic people later on, the outcomes are much better. It was a small study, but it did show that. That was only a very, very recent publication. There is a policy that we are trying to develop in the UK, which will, and I think I've shown you already that, or maybe I didn't, the outcomes are best for the under 12s. Overall, in terms of allogeneic transplants from sibling donors. So there is a policy now being developed which will allow the NHS to routinely commission asymptomatic children with sickle cell disease, provided they have a stem cell donor within the family. For that to happen, we need to move mountains, but I think as time goes on, there is sufficient data being accrued to support universal pre-complication transplants in patients. The main problem, as I see it, is the long-term risk of fertility, which is a very big thing in the community to which most of our sickle patients belong. Many communities they belong to, but all those communities, fertility issues are really a big issue for them. Even hydroxycarbamide, the uptake of hydroxycarbamide has been, the challenge has been because of its, is presumed reduction in male fertility or presumed reduction in male sperm count, so to impose universal, it's not imposition, it's a choice. And interestingly, there was a study published in New England Journal of Medicine in the 80s, where they were in the beginning to do transplants in sickle cell, and they gave the mothers and parents, the option of what would be, in theory, the risk of death that you would be willing to take versus cure, death versus cure risk, and they were willing to take a risk of 50%. So 50% death, they were still willing to take a risk. You can see that with our data that the risk of death is virtually negligible. So for some families, that concept of cure is really important. For some patients, the concept of cure is really important. We have a 58-year-old we've just transplanted for sickle cell. Again, the fertility issue is a big thing. So reduction of that fertility problem. That's why gene therapy is also a big problem, because if you've got, busulfan conditioning, you've got 90% risk or more of infertility. I mean, there is fertility preservation happening all the time, and it's all available, but, with male fertility preservation, we all know that we don't even have the technology for the baby, the testicular tissue, what happens afterwards. But it is being preserved.
I know the outcomes are not being measured for long. Are there any signal coming from off-target leukomegenesis?
Yes, that's a good question again. So the gene therapy for the current available product, which is Excel, there was a big flutter about 3 years ago when a patient developed, 3 people died in the end in the study. And all 3 people were investigated. The program was put to a stop, and effectively what they were able to show was that the gene editing treatment did not have any sufficient off-target problems for it to have caused the MDS-AML. So essentially, the only off-target change that was noted in these patients, which was not there beforehand, was a gene that is not a hematopoietic gene. So it was some gene to do with bone, or not even bone, something else, I can't remember. So what they essentially said was that it is the myeloablative conditioning that would have caused this. We also know through population studies that people with sickle cell anemia, just by dint of having a very inflamed and high turnover marrow, have a higher risk than the baseline population of many kinds of cancers. The one other thing to say is that this mixed chimerism, low-intensity conditioning paradigm for adult patients, there is some concerns about myeloid, cancerous transformation, I should say, not myeloid. So the NIH have published a series where they've had 5 or 6 patients with transplant, 5 or 6 out of about 250 who have developed cancers, but there is no single type of cancer that they've developed. There were like 2 AML, MDS AMLs, there was 1 lymphoid, there was another solid tumor, so it was a mixed bag of cancers. So I don't think we were able to necessarily conclude anything from that, but people are aware that this might be the case. So younger patients currently, the idea is to try and achieve as much full donor chimerism, not mixed chimerism, as possible. And one of the things that we have decided in the UK is that we are going to use the haploidentical platform, including post-Psi, in sibling context to improve that conditioning, improve the chimerism. Yeah.
Any other questions?
Thank you so much for your excellent talk. I was just curious, there's one school of thought in the sickle cell, sort of when it comes to clinical trials and things, that the idea of VOCs leading to hospitalization is a real barrier because...
The what, sorry?
The idea of having VOCs leading to hospitalization as
Yeah.
a criteria for patients is quite a barrier for, having these patients included in clinical trials and things, because a lot of them kind of have learned to manage them at home over time, so they don't actually end up coming to a hospital. Do you think having that as an inclusion criteria for Casgevy is also would that act as a barrier for having these patients come to treatment, for XSL or no?
So your question is that if we were to increase the eligibility to people who have vaso-occlusive crisis events at home, would they then be able to?
Yeah.
I'm not entirely sure that is the case, because the misgivings will not necessarily come from not wanting to come into hospital. I think overall, I'll give you an example. So I've mentioned this dilemma we have with patients that we have put on transfusions because they were severely affected and not responding to hydroxycarbamide. And then they've passed 3, 4, 5 years of excellent quality of life. They only come in every 6 or 8 weeks, have an exchange transfusion. They're not even on iron chelation because the exchange transfusion is causing them to be in a neutral iron balance. We are then telling them that you should, we can't, although you are on transfusion, we know that before you were on transfusions you were getting all this pain, you cannot be eligible. You cannot really tell them to come off the transfusion. It's not ethical for us to do that. But when patients read between the lines and then come up with this, they will say that, I do not even want to experience pain at home for me to be eligible for this transplant. So I don't think it matters where the pain is happening or whether they're needing to come in or not. Yeah.
I think that brings an end to the morning's session.